Welcome and thank you for standing by. At this time, all participants are in a listen-only mode. During the question and answer session, please press star and 1 on your touch-tone phone. Today's conference is being recorded. If you have any objections, you may disconnect at this time. I will turn the meeting over to Ms. Pam Hine. Thank you. You may go ahead.
Thank you, Mia. Good afternoon, and welcome to today's SOAR webinar on HUD's Centralized Intake and Coordinated Assessment System, and answering the question, what does this all really mean for SOAR providers? Today's webinar is presented by the SAMHSA SOAR Technical Assistance Center at Policy Research Associates under contract to the Substance Abuse and Mental Health Services Administration of the U.S. Department of Health and Human Services. Again, my name is Pam Hine with the SOAR TA Center. Before we officially begin the webinar, I'd like to introduce Kristen Lutfer, Project Director with SAMHSA SOAR TA Center, who will give our welcome this afternoon. Kristen?
Thanks, Pam, and hello, everyone. Today's webinar is the second in our 2015 series, and we're planning on hosting a webinar at least every other month with maybe a few extras snuck into the off months. We'll be covering topics that include outcomes and promising practices, transition-age youth, peer supports, employment, and more. We are also participating in a SAMHSA Housing and Homelessness Resource Center webinar on February 4th, on which we'll be talking about funding for SOAR programs. We invite all of you to participate in that. But that's the future. So looking now to today's webinar, we know that many in the SOAR community are taking part and have lead planning roles with the various SOAR groups designing their COC's coordinated entry systems. Excuse me. This is difficult and technical work, much like SOAR, but it's encouraging to know that SOAR leaders are in the unique position to make sure SOAR is integrated into this new system. Today, you're going to learn about coordinated entry from 3 individuals who play a central role in their states and cities planning for this important systems change. I'm going to turn it back over to Pam to take you through some instructions and the agenda.
Thanks, Kristen. So a few instructions before we begin. As the operator mentioned, this webinar is being recorded and will be available for download on the SOAR website. Your lines will be muted throughout the webinar. When we get to the question and answer period, we'll remind you of the instructions after the question. If you look to the top right corner of your screen, you will see an icon that looks like a document or handout. This is where you can download the PowerPoint file from today's webinar. At the conclusion of the webinar, we will send you a link to an online evaluation. We value and appreciate your feedback and use it to improve and inform future SOAR webinars and activities. So let's review the agenda for today's webinar. On today's webinar, we have 3 individuals who many of you may be very familiar with. We are honored to have Will Connolly, who is the Director of Metro Homelessness Commission in Nashville, Tennessee, present today. Will, as many of you know, used to work for the SOAR TA Center, and prior to that, he was with Nashville's Park Center, where he introduced SOAR to the Nashville community. Now he's back in his hometown leading efforts to ending homelessness in Nashville. So we're very lucky and honored and happy to have him back with the SOAR team today. In this webinar, we'll be sharing some of the community entry development in Nashville from its early beginnings up to present time. Next, we have Chris Linenberger, who is our Texas SOAR State Lead, and he also wears the cowboy hat of Program Development Specialist with the Texas Homeless Network, THN, in Austin, which is the lead agency for implementing the Texas-wide coordinated entry system across roughly 250 counties in Texas. And finally, we have Cindy Crane, who is with the Tarrant County Homeless Coalition, who will share how SOAR has been integrated into their model, which hopefully will be utilized across Texas. Just a little bit about the purpose of today's webinar, why we felt it was important to include this. As you know, as many of you may know, the coordinated entry is required by the U.S. Department of Housing and Urban Development, which has asked all of the continuums of care, the COCs, to adopt a centralized or coordinated intake and assessment system. And many in the SOAR community are wondering about where does this all lead, where do their SOAR programs fit in. And we know that many SOAR providers, SOAR local leads, and state leads have been part of work groups to develop this system. So we're really happy to be able to explain this, provide an overview of what this is all about, and to hear from, three individuals who are not only very involved in SOAR, but also, leaders in their communities to really see that this is implemented according to the requirements of what HUD is looking for and their local needs as well. So just an introduction to the HUD Coordinated Assessment System. So again, you'll hear coordinated assessment referred to as several different names: coordinated entry, coordinated intake, coordinated access. So if you will, you'll see the acronym CE. So that does stand for coordinated entry for our purposes. So it's really providing people a way of really entering through the front door homeless services in their communities, and that from what you'll hear from the speakers are really how they've been able to kind of work together to be able to provide services in like the most efficient way so that folks really get their needs met as early on in the process through very, very tailored and with the goal of having a common intake tool that will be used. So again, with that goal of ending homelessness in the respective communities. So before we begin, we would like to ask and just kind of gauge folks' familiarity with this coordinated entry system. Again, this is new, and so around the country you'll see this in various levels of development, just like SOAR programs out there. So our first poll question, and we put it in terms that many of you out there will be familiar with. We really want to know, what is your level of familiarity with HUD's coordinated entry system? So again, if you've never heard of it, none. To the folks that would put extreme, I participate in your work groups, and you're really part of the development. So none, mild, moderate, just so we know really how much of this system's change you are familiar with. I'll give you a minute to kind of look those over and see which one best fits your familiarity. Okay, this is encouraging because we do have some moderates, so people that have really heard about it and know a little bit about how SOAR fits into their systems. Maybe another 10 seconds. Okay. Well, we'll wrap this poll up, and as you can see, it's roughly, still more than a third of you are familiar with it and may have been asked, to include information about your SOAR program. But then there's, maybe 3/4 of you that, or roughly half, that really don't know too much about it. So I hope, and we are encouraged that this presentation today will answer, many of your questions, about the system. So thank you so much for participating in that poll. It really gives us a good idea. So without further ado from me, I would like to introduce you to Will Connolly, who will discuss how things are going in Nashville. Will, would you like to take over the mic?
Yeah, thank you so much, Pam and Kristen. I'm so happy to be here to help share part of Nashville's coordinated entry story and the journey that we've taken over the last year and a half. I really hope that some of our story is helpful to you and your community in some way. And if you're listening to me and you think of a resource or a strategy or something that you think could help us in Nashville, please reach out to me sooner rather than later. We are still definitely in the early development and implementation stages of coordinated entry in Nashville, so we need all the help we can get, and it sounds like that might resonate a lot with you guys who are on the call. So So these slides, like Pam said, will kind of take you through where we've been and where we are now and where we hope to go in the next 6 months. So I want to try to work these slides here. Oh, wrong way. Okay. So to start off, what we've found is that implementing coordinated entry is just really freaking hard. And that's probably a no-brainer, but we're talking about, when we're talking about coordinated entry, we're talking about making radical change. So organizations are changing the way that they prioritize people. They're changing the way that they receive referrals. They're changing how they're being rated on performance. And also people who are experiencing homelessness are, their experience of the system should change radically. So anytime that we're doing that, it's going to be tough. And so I didn't want to be a downer right at the beginning, but just wanted to be really, just be realistic and show you kind of this image on the slide of that's what I think of when I think of like continuously tough situations, pushing that boulder up the hill and having it roll back down again. An extra credit for anybody that can name, who's in that image there. So maybe use your chat box or something. So with that in mind, like it can be so difficult to think through all this stuff that there's this temptation to want to get it perfect on paper. And that can lead to what a lot of us have called, planning paralysis, or just, meeting and meeting and meeting and not really taking a first step. And so early on, we decided to embrace this motto, which is what you see on the left here. It's a Latin phrase called, it says, or when you translate it, it says, it is solved by walking. So the idea is that we need to start acting. We need to get out of that planning stage and start acting as soon as we can, even if that action is imperfect, because we'll learn more. Excuse me. We'll learn more and we'll do more if we act and get out of the office and get out of the planning room. So the picture on the right is kind of a joke, but to me it sums up that motto on the left. So this like ratty sheet of paper that stuck on the wall with a bunch of marker, with a bunch of stuff marked out on it, like that was our strategic plan to start a 100-day effort where we were going to house 200 people. So that was our our big strategic plan there. It took all of like 1 hour to put together, and so now we got a lot done, and now we're kind of going back and cleaning up the mess and kind of formalizing some of the processes that we created during that like really intense time of action. So we have like really attractive outreach staff in Nashville. So this is a picture of 2 outreach workers. No, the guy on the left is obviously Anderson, or the guy on the right, excuse me, is Anderson Cooper. Ingrid is on the left, and the reason why I put this in here mostly is to show you the logo that's on her shirt. That's the name of a local campaign that we started called House Nashville, and it's really just a group of homeless service providers that and other stakeholders that came together to start setting goals together. So shared goals around housing and housing retention, and also just speeding up the system and making it, trying to get to those goals that Pam mentioned earlier. So people are able to move through the system quicker and get what they want and what they need sooner. So this movement that we started, like it's really just a logo with a catchy name, and we did some social media and some marketing, and like just started setting simple goals together, and we found that by doing that we could get more done. And so I'm just going to go through some of those goals because they align with coordinated entry some. So, but before I say that, I should just mention that House Nashville was kind of the 100,000 homes campaign in our community, so it led up that effort, and so you guys may have heard of that national campaign. And now it's the Zero 2016 lead for Nashville. So here are the three basic goals of that campaign. So increasing housing placements for folks who are experiencing chronic homelessness. So our first goal is to increase the housing placement rate to over 2.5% of our point-in-time count. The second goal was to simply to maintain a housing retention rate of 75%. So people who were in housing for at least a year, we wanted at least 75% of those folks to be in housing a year later. And then the third goal, which has more to do with coordinated entry, was to decrease the time from streets to a lease. And so as you see on the slide there, we wanted to share more data with each other, like regardless of what agency or organization we're in. We adopted a common assessment tool called the VI-SPDAT, which a lot of you guys I'm sure are familiar with. And we just started testing new ways to work together that have dovetailed kind of into our coordinated entry efforts here locally. So we started using Google Docs, for example, just to share data. We started meeting together on a weekly or bi-weekly basis. And we started reporting housing placements and housing retention data to each other and really holding each other accountable and watching how people in our community move through the system or how they don't move through the system and what the barriers are there. This is so the next three slides are kind of correlate to those three goals. So this is data, housing placement data since the start of House Nashville. So we started House Nashville in June of 2013. The month before that, on average, 19 people were getting into housing each month. So we went from 19 to 44 in that first month. So a huge jump, and it just shows you kind of like just the power of getting together under one banner and like one work group and setting these shared goals and learning from each other in that way. And that immediate success kind of led to more people and more stakeholders getting on board for this effort. So you really need some early wins, early successes to show people that this change is worthwhile. And so now we're averaging 44. Like you go all the way to December 1st of 2014, last month. We're averaging 44 people per month going into permanent housing, and those are folks that meet the chronic definition of homelessness. We're not satisfied with that number. We need to make another leap, and we hope to be closer to 100 in the next year or so. The second goal was housing retention, like I mentioned, and this is just a screenshot of our housing retention report that we send out every month or so. And so for folks who've been in housing for a year, we went back and checked in with them and asked how they're doing, asked their service team how they're doing, and found that 77% of folks are still in permanent housing a year later. So we're pretty happy with that, and that's a testament to the service teams that are supporting folks, but also it's a testament to people who are in housing and their resilience and strength and ability to make that ridiculously difficult transition from the streets to housing. And the third goal, like I mentioned earlier, is just getting more coordinated and decreasing the time to housing. So on the left here, you see a guy administering the VI-SPDAT, and he's on the right there. And he's what we call locally a housing navigator. So he's trained on how to do the VI SPDAT assessment, obviously, which takes, about 15 minutes or so, depending on the person. And then he's also trained, it's kind of like a SOAR, like someone who's trained in SOAR, but for housing. He really knows how to put a good housing application together, and he knows more about housing resources and where to turn in that paperwork and all of that. So locally, we have a 2-hour housing navigator training that we provide for free to frontline staff, and they use the VI SPDAT out in the field, and that data, the VI SPDAT score basically opens the front door to all the resources that you see on the right here. So Section 8 vouchers that our housing authority has worked with us to make available, and then you see some other like COC funded housing. We also have been working some with private landlords to discount rents for units, and so you have to have a VI SPDAT assessment done to get access to those units. And we manage a flexible fund for move-in costs. So like a lot of you guys, I'm sure, you see that it's expensive to move from the streets to an apartment. You need deposits and mattresses and bedding and utility assistance and things like that. And so we asked our community to donate money for a flexible fund, and we made a call for $1,000 per person and quickly kind of built up this fund to help pay for those costs. So, and then the final kind of resource is our support services. So we try not only to match people to housing, but also to support services or case management. And eventually we want this to be, we want our common assessment tool to help coordinate referrals for SOAR and other services. So there are a bunch of benefits to using the VI SPDAT. We know, of course, there are limitations to the tool as well, and we are currently considering locally, like if we want to continue with the VI SPDAT or if we're going to use another tool or like a hybrid version or something like that. But it's really been helpful, I think, in terms of prioritizing the most vulnerable. Like we've been trying to match those resources to people who score really high on the VI SPDAT and who have really acute needs. So it does a good job doing that, but it also just helps us tell our story locally. And this is an infographic that you see here of some of the data that the VI SPDAT collects and some of the data that we've been reporting. And so it just, you see really high rates of chronic homelessness and ambulance and emergency room visits and stuff like that, and it can help kind of make the case to funders and policy folks and just other stakeholders who may or may not know much about the work that we do. We've also been trying to do more process mapping. So as you guys know, like the homeless service system can often just resemble like this maze where you have like no idea. If you're experiencing homelessness, like it's hard to predict what's going to happen next or how to get a certain resource. And so whenever we can, we've been trying to develop tools that show kind of the path from streets to housing. And we make these tools available to frontline staff, but also to people who are trying to navigate that system, so people who are actually experiencing homelessness. And, sometimes the path, like, obviously the path is more complicated sometimes, but it's just an attempt, to just add some predictability to the process, and I think any effort to do that is appreciated by, especially by people who are on the streets and trying to access resources. So this is this infographic and the last one are made like we made them pretty quickly using a program called Easily, which you can just Google and find, and it's free. Okay, so now I'm kind of transitioning now to what we are, like where we're headed. So that was kind of what we've been up to the past year and a half. We increased our housing placement rate quite a bit. We've, had these housing retention numbers that look pretty good, and we've been working with a common assessment tool and trying to coordinate our efforts, but we have a lot to work on. This is kind of embarrassing, but all of that VI-SDAT data has been going to one giant Google spreadsheet, and it's a pretty sophisticated spreadsheet, but it's it's just packed with data. It's got formulas everywhere, and we're at the point now where we're joking about breaking Google, and we'll accidentally delete a formula and spend a couple of hours trying to figure that out, or it'll just freeze up or something, and we're stuck. So we're now but using Google was helpful because it helped our community take a couple of baby steps in terms of sharing data. So you may find your goal may be to use HMIS, which is a good goal for your coordinated entry system, but initially you might see some resistance to that, right? So a lot of communities start out by not necessarily focusing on HMIS, and they use some other tool, and we decided to go with Google, even though HMIS is the goal. So now we're transitioning to a new system called HomeLink that will communicate with HMIS, and it'll also just collect the VI-SDAT data and allow people to upload documents and IDs and birth certificates and housing paperwork and stuff that you need to get into housing. And so it'll kind of help us manage that housing navigation process. So moving forward, I think I may have, okay, cool. So you guys may have seen these before. These are just guiding principles of our coordinated entry process, and they're not in any particular order. I guess if they were in order, the person focused would probably be number one. So we don't want to create a system that, that re-traumatizes anyone or makes it more difficult to get to a resource. So we're trying to, make sure that it's person-focused, just like SOAR, and that people get what they want and need sooner rather than later. Data, of course, is key. We're trying to learn a lot about our system and what the real demand is and what kinds of interventions we really need. And it's hard to do that if you don't have data. It's hard to know if you're even making a dent in homelessness if you don't have good data. So, you can increase your housing placement rate. You can, celebrate the housing retention percentage, but you still don't really know if you're ending homelessness. So we are really trying to get to a point where HMIS is the data hub, even if not, even if everyone's not using the system directly, it's at least the hub. And then the other ones are pretty self-explanatory. Housing focus, so there are tons of ways to respond to homelessness, and often housing really isn't part of that response. So we want to make sure that that we're talking about permanent housing and that it's the only cure to homelessness, and that the pathway goes from the streets or shelter eventually to permanent housing. And I'm going to skip over simplified access, but just the last point is a little problematic, serving the hardest to serve, which is probably it's probably a sore ouch in a way, because I think a lot of us are probably hard to be with. I know we are. So, but really just, people who don't do well in traditional homeless programs, like those are the folks that we're trying to get into permanent housing and build the system around. We've a couple more slides. So we are trying to roll out this new and improved coordinated entry system and to kind of start the first phase of that on July 1, 2015. So we have about 5 months or so to improve the coordinated entry system that we have, and we felt like we needed a date, that we needed to set a date to kind of create a sense of urgency, even if it's 5 months away. So there's a flow chart on the right, which I don't expect you to read, but we again have been process mapping it and trying to figure out exactly what the model is going to look like. But we definitely want some sort of hotline to help improve our prevention and diversion services, and then we also want to have more in-person locations where people can get assessed and prioritized for housing, and also just add more housing and service resources into the system. So right now we've been prioritizing people mostly for housing and not for services like SOAR, and we really need the SOAR community's help on trying to figure that one out. So this is almost the last slide, but these are a few of our amazing AmeriCorps VISTA members. And so if you guys have been hanging around SOAR for a while, you know that we promote the use of AmeriCorps and VISTA in SOAR programs. So we applied for a VISTA program to help expand coordinated entry or really build coordinated entry in Nashville. So we have 3 VISTA members who who volunteer full-time, and they're not just like token members of our team. They actually lead meetings, and they're really impressive, and they do a lot of research. They interview people who are providing services. They interview folks who are on the street and in shelter. They try to figure out the best way to roll the system out, and we're really grateful for them. Nuts and bolts, well, anyway, the funding for AmeriCorps VISTA, the cost of it was, I think, around $11,000 or $12,000, and that was for 4 VISTA members for a whole year. So it's definitely a really cool investment for your community if you can propose something like that. All right, and so our next steps are, we're meeting every week to launch this new system by July 1st. So we had a meeting this morning. We meet every Wednesday morning at 8:30, and it's a pretty small team, but broad representation, and we're just trying to follow through on our work plan to get this thing going. We are gathering eligibility criteria for more housing and service resources that we can include in the system, and then we are eventually going to develop policies and procedures and governance structures and things for the system. And finally, throughout this whole thing, we're trying to show the value of this new system to more people to get buy-in, and we kind of jokingly call that the COW, or the Coalition of the Willing. And so we're trying to get more people to be, to think of being in that coalition and participating and seeing, the need for it instead of, shoving it down their throats and saying that it's tied to funding or really trying to mandate it. We really want people to come in voluntarily. So I think that's all for me. So please feel free to email me. Of course, I'll be on the line for the Q&A later on. And yeah, thanks for your time.
Well, thank you so much for sharing up to the minute, knowing you had a meeting early this morning with what's going on with Nashville and all of your planning and development efforts. We appreciate that. And also sharing that the coordinated entry is so client-focused, which I know folks applying for Social Security benefits through SOAR really appreciate that, and that it's designed in a way where applicants don't need to be asked the same questions over and over again and be re-traumatized. So I really do appreciate that. I think we're all learning something new. I know I am. So thank you again so much for that. And we're just going to do something a little fun in the spirit of making our webinars a bit more interactive. So we want to see how closely you listen to Will's presentation. So this is a tricky one. So true, false. Will's, the program that Will is talking about, HOUD Nashville, is a nonprofit which has been solely responsible for setting Nashville's goal and is accountable only to Anderson Cooper. Is this true or false? I'll give you a few seconds to answer this one. Okay. So it looks like overwhelmingly that is false, although we do have a few people who think that's true. So maybe, we'll answer some of your questions in the Q&A, but certainly that is false. It takes a village, as Will said. It's a group of committed individuals willing to come together and join in sharing their resources and all that good stuff. So we do appreciate you participating in this poll. We wanted it to be a little fun for you all. So, I see some folks went back to the false, so that's good news. Okay. So next, presenting for us, so yes, it is false. So we want to hand the mic over to Chris Linenberger, again, who has put a lot of miles on his car, crisscrossing Texas with working on the coordination of their program. Chris, I'm going to hand it over to you.
All right. So I just wanted to say hello to everybody and good afternoon. I actually am coming to you guys from my car in San Antonio, Texas, where we're actually doing a SOAR training right now. So we're kind of right in the smack dab of things, but, I wouldn't have it any other way. This is just kind of the way things go down here in Texas. So you should be seeing my intro slide right now. So the Texas SOAR and Coordinated Access. And really what I wanted to do today, before Cindy Crane gets on the line and really talks specifically about what's going on in Fort Worth and the Tarrant County area, I really wanted to give you guys kind of a global perspective of what's happening in Texas and what the agency I work for, Texas Homeless Network, some of the things that we've done around SOAR and around coordinated access. So, and I know the terminology is a little weird. I know Will said coordinated entry, and there's coordinated access, and then I've also heard like coordinated assessment. So all these terms are just referring to this one point of entry into the system. So the term I'll be using is coordinated access. So if you go on to the next slide, so just briefly, Texas Homeless Network is, or THN, is a nonprofit based out of Austin, Texas. And, of course, we're a membership-based organization, and we provide solutions to ending homelessness in Texas communities through education, resources, and advocacy. And so really what we do is we work with any agency, any county, any coalition or COC that's out there within the Texas state line, and we work with them around, getting them the trainings they need, getting them the resources they need or linking them to the resources, and, of course, advocating for them. So feel free to visit our website. And then go on to the next slide, please, Pam. I just wanted to kind of show you kind of how busy we are down here in Texas. Just for our training and kind of what we do on a regular basis. And, of course, this is not including all the webinars we do on a monthly basis to get all best practices around the state. We have many other statewide trainings that are happening. We have actually a summit coming up this spring on healthcare and housing, and then we follow that up with Case Management Institute. And then that group of trainings is followed up right after the summer with our big conference that we do in September, October of every year, where we have typically over 450 people attend our conference, and they come in from around the state, from service providers, other agencies, even some government officials, to really get an idea for what's going on around the homelessness needs and around homelessness interventions across the state. And so we fill that time with workshops and other pieces for everybody to get educated. And then finally, down at the bottom, you'll see that I typically load every summer up, starting in the spring, with all kinds of trainings around SOAR, just basically because my main focus is, being the Texas SOAR lead, is really making sure that we implement SOAR within all of the Texas DOCs to an extent where we are getting outreach to the community. And we are actually getting down on the community level, and my agency is giving those communities the support that they need. You can advance to the next slide. So just if you're not familiar with Texas and kind of what goes on here, you should see there a map of Texas. And within THN, what we do is we serve all of the continuums of care. So that actually is 14 continuous. And then, of course, within that 14 continuous, we also serve the balance of state area. So you'll notice that there's a bunch of orange on that map, and that orange represents the balance of state. And so that, at this time, represents 213 different counties around the state that we are constantly trying to get resources around and try to work with and just incorporate different implements of how to serve the homeless population. So we're very busy down here in Texas, really getting things running, specifically around SOAR and implementing SOAR, and as well as coordinated access. If you advance to the next slide. So I wanted to talk just briefly around what has happened within my office starting in 2013. And, you know, of course, in 2013, 2014 is when we really started to hear discussion around coordinated access and what this might look like, how it should be implemented, or what it could look like if it's implemented. But before I could even focus on that, and other people in my office could even focus on that, I was still focused on SOAR and how to bring SOAR out across the state to all the different COCs across the state. And so in 2013, we had some realizations that came across my plate. And first of all, we had been doing training, SOAR training specifically in Texas since 2008. So we've been training for a good long while. And of course, I have not been here that long, haven't been responsible for all those trainings. But I had done quite a few. And we had many, many people that were trained in SOAR, but yet not many people that were using the SOAR process. And so what I really saw then, and what my department saw then in 2013, was that this model was just not sustainable in the way that we were implementing it. There had to be some decisions that were made kind of on our level when we're working with all those different continuums around the state. And so we started scrutinizing what we'd done in the past and what we wanted to do in the future around SOAR specifically. And we realized that what we really needed was community support. And we needed to find, individuals that were either trained in SOAR or get individuals trained in SOAR that could be embedded in each community and really serve as a lead or serve as somebody that could really be that community's voice. Because we are just located in Austin. We know kind of what's going on in Austin, but I don't know what's going on in Amarillo or El Paso or Brownsville or any of those different areas. So I needed to build a contact network of individuals that I could call upon to really define what were the needs around SOAR and around meeting and helping that mental health population. So at that time, we underwent some changes in how we were rolling out our program and how we were doing our work. So Pam, if you go to the next slide, entitled Texas SOAR Changes. Essentially, we came up with 3 phases that we implemented in order to work with the COCs, those 14 COCs around the state. And so there were 3 different aspects of each phase, or there's 3 different phases and multiple aspects of each. But it was pretty simple. First of all, what we really tried to do is make this a COC-driven model. So we started with the planning aspect, and we started with strategic planning meetings. And so starting back in 2013, I started going out to the different COCs and meeting with them and doing, you know, a half a day to an all-day kind of a strategic planning meeting or a source planning meeting where we kind of we talked about SOAR. We really invited the program managers to be there to get a commitment in the model and really to discuss what SOAR would look like if we implemented it in their community. And so we really had some great discussions. You know, we started that a while back, and it's something I'm still doing now. We're still rolling that out. I'm still having these kind of planning meetings happen. And so we're kind of wrapping that up, but it's just kind of this pattern, the circular pattern that's happening. The second part of that is really the training aspect. So at that time, we were looking at the 2-day trainings. Now we're really focused more on the web-based training of SOAR. But we were really focused on the COC really getting involved with the trainings, helping us kind of reserve the space, helping us pull the invitation list together, really incorporating the COCs or the coalition in every aspect of the training. And so we really want to do, THN really, what we really want to do is incorporate what the COC wants to have happen in their community around SOAR. And so typically we invited those that the COC identified, whether they were from the hospitals or from the school districts or service providers. We invited everybody to the table for that training to get trained initially. And then after that, the follow-up phase, that third phase was really making sure that we have implemented SOAR leads in every COC, as well as starting and really endorsing steering committees. So really committees that could take the SOAR work to the next level. A committee or a group of individuals that would meet, whether it was 2 or 3 people or 8 people, that would meet on a regular basis and talk about what was happening with SOAR in their community and what could change, what needed to be strengthened, what were maybe some weaknesses, and really hit on all those implements. So that was, you know, basically that 3-phase concept, really getting out to those COCs, working with them, you know, doing the planning up front, getting everybody engaged, doing the training, and then after that, really helping to provide support around helping develop a steering committee and then helping develop leads in those areas. And of course, that is something that I am constantly engaged with all the time. We have many different COCs, so all of them are at a different level or in a different phase. You know, some of them, as in the one I'm at today, is still in the training phase. Other COCs are, you know, fully past that training phase and into, you know, developing those steering committees and getting that ball rolling. So if you'll advance to the next slide. So we had some realizations within my agency of as we continued on with this process of these different phases and as we started that talk around coordinated access within Texas. And a couple of the realizations that we had is that, you know, we knew that coordinated access was going to be integral. But, you know, it was going to need to be integrated into each COC independently. And they really had to have that ability to design their own system and do all that. And that by no means was not something that we were looking at doing, but we really had to kind of start talking about that. And more specifically, you know, how that system will implement SOAR. How can SOAR, the SSI and SSDI access piece, be implemented into their coordinated access system? And more importantly, for me, it was more about how do I make this an easy on, or how do I make this easy to incorporate for a coordinated access system? You know, what can I do to help those COCs around the state easily implement SOAR. That way it's a piece of your system, and it's something that, is not a hassle to implement. And so the biggest question there was how do we do this? And I love the kind of the caption over to the right with the dog. We caught it. What do we do with it now? So it was kind of like we got the ball rolling. We have the discussion on SOAR. We have all these things going. What in the heck do we do now? And so if you'll move to the next slide, we had to have some conversations about approach because we just didn't know really what approach to take around coordinated access. As Will mentioned, it's a big monster. It's a big undertaking. And so we're really looking at different models and different schemes and, different ways to help COCs implement this coordinated access. But essentially, it was up to each COC to implement. And so what I've given there is just kind of a brief model, something that we looked at briefly and something that we pushed out to the different COCs with some toolkits and stuff that we did of just a different way or a different kind of way to implement the coordinated access model. And so kind of through this, we weren't necessarily looking at SOAR specifically. We're just looking at the different models and really just doing some research for those coalitions out there and those COCs out there and giving them some instruments to kind of look at the different coordinated access programs they could use. And so what I want to do is, so that next slide is really to introduce you guys or have you guys meet Tarrant County. Now, what I have to say is that Tarrant County, they do a great job. In fact, I was there probably 3 or 4 months ago and met with Cindy one-on-one, and, she just does a wonderful job in implementing, that coordinated access system and implementing aspects of SOAR. And so that was something I was very, very excited about and seeing how they're bringing that all together. So yes, their executive director is Cindy Crane, and they have this robust coordinated access system, and they do a great job. They were one of the COCs in Texas that really just got it up and going and did a wonderful job. I can't say enough. So they didn't need that much help from us. Cindy is a go-getter, and she just got the ball rolling. So that's all I have to say.
Thank you so much, Chris, and get back to your training and appreciate your very detailed presentation and all your hard work and planning. Thanks so much.
Thank you, guys.
Okay. So Chris did a great introduction of Cindy. So I'm going to let Cindy continue with the great work that's being done in Tarrant County, which includes Fort Worth.
Excellent. Thank you for that introduction. And I wanted to start and let folks know that within our continuum of care in the program year 2012 continuum care grant, we applied for coordinated access, an SSO grant, and we reallocated funds from other programs that might have been subject to recapture to fund it. And just some kind of basics about it, it was a $155,000 grant, and it supports about 2.5 FTE and a little bit of technology. So we had just completed our first year. Our program year ended in November, and I am literally in the process of writing our very first, or responding our very first APR and ESAPs on coordinated, or what we're calling our CAS system, Coordinated Assessment System. And so I really want to talk about just how we are implementing the CAS, and specifically as it relates to SOAR. I'll let you, I'm the executive director, but it is my deputy director who really is that SOAR steering committee lead. I'm more on the coordinated assessment side. Rebecca had a baby 2 days ago, so she's not with us, and I will apologize in advance that I have my annual post-point-in-time count place. I wish I sounded like Kathleen Turner, but I sound more like Marge Simpson from Sisters. And so I'm going to, if I have a coughing fit, I think I've got water and everything ready to go here. So let's go. Part of success in the continuing care is, you just have to use the say, give you credit if you took SOAR training. And it was clear that after 3 or 4 years of just SOAR training, that it takes more than that. You've got to really step up and say, to make SOAR work, you have to make it a priority in your continuous care. What you see here is just kind of like a screenshot of what we have, like just a tablet sheet of paper, and it has the 5 objectives. Those new NOFA program year 13 objectives that you had to address, and number 4 was to increase participants obtaining mainstream benefits. And when we put this together and presented it to the new Continued Care Board of Directors, we had finished our Hearth Act, redesigning all the governance within our continued care. It meant something to just put it in the plan, because then it had to be something subject to quarterly reporting. And so this was able to get us to focus, and also for those leaders who are not continued care players, meaning they're not grant recipients, they're the other distinguished leaders in our community. It was teaching them the language of SOAR and what it meant and how the process was going. And so this kind of kept us checking about to make sure that when we committed to it, that we reported on a regular basis. And you can't quite see it, but one of our action items was we're going to apply for that SOAR National Technical Assistance Grant. We did, we got it, and that helped us to begin that planning where we combined the two. And so that was a pretty, the process for that. You apply for the grant, we got the grant, and the TA came in, and we did one of those all-hands SOAR forum meetings in August, and identified 2 key leaders within our continuum of care that would participate in that SOAR Leadership Academy. And one was Rebecca Cox, our Deputy Director, someone that was very influential within case management training, and so that we had that centralization. And then someone from one of our primary mental health provider, MHMR Tarrant County, so that we had the technical side of someone who really knows about the benefits and had actually done many SOAR applications for their clients with the person who could really instigate systems level change. And so we went through the process, had a much more an implementation plan. Literally was based on where are the gaps and the holes in our community, what needs to happen to make all that happen. And so that SOAR, those steering committee meetings started meeting in October. And one of the primary things that it focuses on, and they just started the staffing the tough cases. Literally, that is a core part of those meetings because that's directly related to our other goals of housing and ending chronic homelessness. And so I just wanted to share kind of some of those basic work groups. Obviously, we're looking for that medical work group, and streamlining the access to medical records. Looking at our hospitals. Another thing that happened at this time, some of you who are representing community cares know that within that COC grant, you have to write about your discharge planning procedures and what about healthcare institutions. That dog had been nagging us for years. We never had a discharge plan. And that finally came together, the committee tangent to the SOAR steering committees, and we now have it just went before the Continued Care Board of Directors, and it's a really basic discharge plan. That took intense engagement from hospitals and doctors. Another part of that plan was getting them engaged in teaching about SOAR. That's our language. And really letting them understand that when we successfully achieve gaining benefits, income for our clients, that is, it's not just about finding housing, but if you can find housing and identifying income source, you're ending homelessness. And when you're ending that homelessness and getting them housed, we all know housing is health care. So there was tremendous amount of motivation within the medical community that they understood that if they helped us with SOAR, we got people housed. And when people get housed, their health improves, and we begin to reduce the number of emergency room visits and repeat visits that they are incentivized from their business model to prevent. So we were very successful in that. And so we have an amazing partner, our county hospital. We're not a Medicaid expansion state in Texas, so we have something called a 1115 waiver program I'll talk about later. But they put homelessness in that specifically for trying to reduce those frequent flyers. So now we have a very engaged medical community. So when we are working on getting those signatures and the documentation of medical records and building that really strong application in case and SOAR, they are at the table. And so the next one is the corrections work group. A little tougher nut to crack for us. Streamlining access to records. Again, this is where MHMR of Tarrant County played a key role because they are already in the jail setting as far as the county jail setting. And training them about SOAR, you know, they're usually dealing with something, an emergency situation, their interactions with certain clients, maybe formerly homeless, those repeat offenders within the mental health world are getting some services, but there's always, again, an opportunity to connect them and talk about SOAR. So as far as coming from the Texas system, prison system, we've got a lot of work to do. So the work group has identified these key things. And we have a recent coalition called the Tarrant Reentry Coalition, operates very similar to a homeless coalition, that is all those players talking about reentry issues. You know, they know corrections. We know homelessness and we know SOAR. So now we've started to engage and do that cross-pollination of efforts to make sure that we identify those individuals. And, of course, one of the most important work groups is, you know, all the work, the outcomes. This is the part that we never figured out when we just kept taking training, is that you really have to talk about outcomes constantly, tough cases. Now, they had to make a decision between the OAT system and the HMIS. And in their December meeting, they said, you know what, when it really comes to tracking, use the system that was designed to track SOAR, and that's OAT system. So that is there. But HMIS plays a very important role when you're building a case. And in our HMIS, it's very robust. We have a section called critical documents. So I'm a client. I'm in the system. May have been homeless a while. My documents, my information, whenever we can, with client authorization, we scan and attach to their HMIS records all kinds of critical documents and information, even photocopies of IDs, photocopies of Social Security cards, anything we have, because the frequency that their wallets get stolen or other things, it's so helpful to have the original there so that we can just do an online renewal of something or have the kind of information we need. Veteran touch points, critical documents of all their discharge papers, D214, et cetera. So we use that HMIS. And another section that we now have in that is those medical records and SOAR records. So maybe you're not ready for the application yet. And maybe this client, you're working with them at this emergency shelter, they disappear and they show up at another emergency shelter. It's okay. It's not a paper file in an agency. It's an HMIS. It's there. So we're starting that OAT process. But still, HMIS, and I'm going to talk about the relationship with the coordinated assessment now, are very much interrelated. And so we haven't had a great deal of reporting yet because we're just getting started. So now we've got to go back. We've got a plan. We've got a steering committee. We've got a mechanism, an engaged medical and mental health community. We still have to seal the deal with these agencies who get distracted by more pressing needs. And so the SOAR training has always kind of been a part of your continuing care participation, be it an ESG grant scoring or perhaps just your internal local continuing care competition. That's a scoring item. We needed a lead agency in everyone to be not, Chris talked about getting a lead within a continuum of care, and we take it to the next level. We need a lead in every continuum of care agency. Again, you identify that. That is another scoring item. And so the next level, of course, will be SOAR successes performance. We already measure in our annual performance reports that mainstream benefits and looking how many SSI, SBI, and we have an aggregate total, but we started to add that also as performance metrics within our continuing care local competition. And once something becomes a competition scoring item, everyone is fully engaged. You get it from the director who pays attention to whether or not their grants are renewed or their grants were funded, all the way down, and it becomes a part of their procedure, and it becomes a part of their case manager training. Okay, so now let's talk about SOAR and my coordinated assessment. And primarily, it's all about that documentation of disability. Now, coordinated assessment, I'm just going to focus on prioritization. Yes, we do have a helpline that tries to divert. So now I'm going to dig into where the element where the individuals actually, diversion was not possible. They're in the continuum care system at some point, and this is sort of where HRIS and coordinated assessment and SOAR meet. This is kind of a very abbreviated way, and these are kind of the 6 basic steps of how we have organized our coordinated assessment system. Case managers are looking for a housing solution for a client in their shelter. Now, before they are actually going to be prioritized, they've got to gather up any documentation of disability that they may have. In other words, we're trying to meet that chronic homelessness HUD definition. And you're going to attach that to your HMIS record. And then you actually formally, through an email, case managers, anywhere in the continuum, email our office and say, I would like to request a documentation of priority status, what we call DOPS, within your system. And so the CAS office gets this information. They go straight to the HMIS record and look at all the things that have been uploaded, and then they give them a priority score. And so what we have is a priority 12 system, a P12 system we call it. It was just 3, and once we launched it, that's when HUD came out with that prioritization notice about the different 8 levels, and so we adopted that. And within this, we are looking at documentation of disability, documentation of homelessness, and we're classifying them. And we have an entire grid system that gives a very key definition that everyone reads to know what your client's priority level is, what number are they. And these are just kind of just collapses of what that is. In the prioritization system, in order to get that severity of service needs, we have a housing assessment form unified across the system, and the third workflow is the VI SPDAT, and it's all automated. So when you hit submit at the end, you get the score of severity of service needs and a lot of information about the client and potential services. So once that's done, that's also looked at. So we look at documentation, disability documentation of homelessness, and the score, and we give them a priority level number. And then these individuals then, once they're prioritized, we produce a priority housing list every Friday. It is dynamic. It is updated. This priority status is good for 90 days. This is something that we make sure that is very dynamic. It can't be like a housing authority wait list where you're on there forever. It's refreshed. People come off the list when they're housed. People enter the list from our unsheltered emergency shelter outreach, and it's a very dynamic system. So if we're checking disability, a couple things can happen here. When we're looking at that application, we may see that there's all this documentation, disability or documentation and health. Boom, if that's being submitted, we make sure that if they're going to meet chronic, sometimes when people are doing those HUD assessments, they don't check that chronic box, or they check it and the person's not actually chronic. So this gives us a quick opportunity to update an HMIS record, which is critically important for annual performance reports, emergency shelter ban, and us getting to 0. And then another, let's say that an easy request, they literally will scan the letter and then show their disability benefits letter. And then we go and make sure that that income is recorded in their HUD assessment because we're wanting to make our continuum of care score. So we always use the opportunity for coordinated assessment to update HMIS records. Sometimes they say they're a veteran, they didn't check the vet box, or they said they were a vet and they're not. And so we use this opportunity. So let's say we're going through, we have this client, and they said, is there disability income? Yes, absolutely, record it. So we're just going to go with our prioritization system. What if they say no? The process now is that we flag it as this is someone who is a potential SOAR application. So in addition to giving this client a potential, we also will email the case manager, your DOPS process has been complete. We noted that you have presented with a substantial disability. You need to contact your SOAR contact at your agency and see and have them review it to see if this is an opportunity for a SOAR application. And so that's really as simple as that. And that email is also that is copied to our SOAR leader at MHMR, those 2 leaders that we were talking about. And this is just trying to close the gap. On our priority list that we put up every month, it's on Basecamp. we have added a column that notes if they do receive disability, because you know when it comes to housing individuals, you get a priority 1, 2, 3, 4 individual, and you've got a score and you've got income. Man, that person needs to get housed immediately. They are low-hanging fruit, chronically homeless. Let's take care of that individual as fast as possible. And so that's just kind of how the two things absolutely meet. Now, when we talk about SOAR collaborations, again, the JPS Health Network 11 to 15 Waiving Program, Care Connections for the Homeless, they now have a walk-up clinic. And all the physicians know, and it's within walking distance of emergency shelters, they absolutely collaborate and cooperate with us. If they see someone, they know that, you know what, if we can get this SOAR, so it's push or pull. It may be that the case manager, the client has never really engaged case management at emergency shelter level, but is engaging JPS, then JPS is going to push it to us, to our SOAR lead, and say, hey, I've got somebody that I think we need to help with the process. So we have two things going. We just started a new medical street outreach. We didn't have street medicine in our community. We have it now. We have a physician assistant, an RN, and formerly homeless community health workers. They understand the process. And primarily, that physician's assistant now on the street knows how critical they are in documenting medical conditions and diagnosis and helping build that record for the application. So they are hand in hand participating. And all this stuff, where we are able, JPS has access to HMIS. We don't have access to medical records, but they can easily document in a touch point and do an assessment. So we know that there is JPS engagement. JPS is a user of our HMIS system, and we're able to kind of do some cross-tabulations to try and identify anyone who might be a high potential for that. The other thing that's been helpful in the state of Texas, we have something called a Healthy Community Collaborative, and this would be beneficial for Chris. There's like 5 communities in Texas, and that actually doubled the size of our street outreach. And all of them are being SOAR trained and making sure that, and they have their key leader, who is an MHMR, that now we're just making sure that we close every gap possible and identifying individuals who are high probability or folks that we want to make sure that we get in our system. And so it's kind of helping just kind of find any gap, any hole, and making sure. And the other thing that we did, it's not just about SOAR. There's a lot of other mainstream benefits that we make sure that we have a contact for Texas benefits and those unified applications for other types of resources in our community. The next step that we've got to take is ACA, making sure that if they're not eligible for one type of health care program, Medicaid, that we make sure that we try and screen them also for any type of health care insurance possibilities for them, especially when they move into transitional housing and permanent supportive housing and their lives stabilize. So we're now working on making sure that if you're going to check these 2 or 3 boxes, you might as well check them all and screen them for these possibilities for advanced improvement in health care with the different resources available. So that's my presentation.
Wow. Thank you so much, Cindy, for sharing such detail, some technical information that provides us an insight into really where that SOAR applicant does fit in and the emphasis on individuals with disabilities and so on. So I really do appreciate that, and your presentation just shows all the hard work that's going on, and that's just wonderful. We just have another poll question for you to see how closely you listen to Cindy, and I think this is really perfect for our SOAR caseworkers out there. So Cindy described that when disability documentation is submitted, the CAS specialist then checks to find out if there is any disability income. If the answer is no, what happens next? So just choose the best answer. Does the CAS specialist direct the client to their local Social Security office? If there's no income, does the specialist process and flag for potential SOAR application and follow the process in place for that? Do they follow, will they make just, simply random phone call inquiries to find out which agencies have SOAR trained case managers? Because really we're not sure in Fort Worth who's doing SOAR case management. So let's see what you come up with this poll question. Oh gosh, this nobody changed because I want to say it's perfect. We have a lot of SOAR caseworkers out there, I can tell, right? We don't want to just direct, but this isn't about directing the client to their local Social Security offices, right? It's not about that. So wonderful, 100%. We really do appreciate it. So I just want to thank Will, Chris, who had to leave, and also Cindy for your wonderful, wonderful presentations. I think you included so much about what you're doing around this topic of coordinated access. So we do appreciate, letting our SOAR community know really what's going on in this area. Because again, it's very new, and folks may be not involved in housing services. They might be involved in their mental health services and not really part of that, the COCs. So again, we thank you so much, and we have, plenty of time to field some questions. That Mia, the webinar operator, she'll come on and share again, with you instructions for asking questions. So feel free to ask questions of either Will or Cindy. And anything that can't be answered, we will try to get some of that information to you. And I do have right here resources slide. So Will's VISTA volunteers actually put together some good resources for you to check out as well. Do we have Mia on the line who may have some questions in the queue? Folks may have been submitting some questions online. So we have Abby from the SOAR TA Center who's going to field some of those questions if we have any that have come in.
Thank you. If you'd like to ask a question from the phones, please press star and 1 on your touch-tone phone. Be sure to unmute your phone and record your name clearly. Again, star and 1 with any questions. You can also remove your question from the queue by pressing star 2. Again, if you have any questions, press star and 1. One moment while we wait for the first one. Our first question today comes from Julissa Rosario. Go ahead.
Hi. The lecture was very interesting, but the problem is that we weren't able to log on, so it was kind of hard to visually see and put together what you were sharing verbally, in comparison to what some individuals were able to actually look at.
We apologize for that. You'll be happy to know that the complete webinar video and PowerPoint slides will be archived on the SOAR website. So you will be able to hear it and get the PowerPoints too. So we do apologize for the technical difficulties, but you will be able to see it within the next few days.
Oh, that's great. That's great. That's awesome. Okay.
Okay, sorry about that.
No, you're good. Thank you.
Again, if you have any questions, please press star and 1 and record your name.
Pam, we do have one that came in online.
Okay.
Okay, the question is, how difficult was it to implement the coalition between medical doctors and social workers?
Okay. Let's see, Will, is that a question you'd like? Building up some of the collaboration among medical doctors and social workers?
Yeah, I didn't talk about that. I don't think we have a coalition like that, or it wasn't included in my presentation. So
yeah, Cindy might.
Maybe that was Cindy.
At the end. Yeah, Cindy, do you want to take that again? Kind of, and it may have been directed more for you, Cindy, on outreach to medical doctors, and I'm assuming the question might be around documenting disability. Seems like you've been doing a lot of work on that, Cindy. Cindy, are you there on the call still? Cindy, Cindy's phone either might be on mute or she had to be called away, for something. Oh,
it's
hi,
not.
Cindy,
They're there?
Yes.
Okay, it didn't say, I took it off mute, but I need an iPhone 6. Okay. Yes. Well, number one, we have a member of JPS Health Network, our primary healthcare provider for the indigent on our continuing care board. That helps to engage and for them to understand the need to trickle it down. The others in that process, when the 1115 waiver program came out, when we came up with our application, I introduced them to the National Healthcare for the Homeless Council. And prodded and said that you will be able to make your metrics that you put in the grant if you go to that national conference. And so 5 or 6 of them, including 2 medical doctors, a new medical doctor, a retired doctor that wanted to give back and is an employee to work at a homeless clinic. So it was just a matter of getting them educated and understanding that. And so once that was done, then they understood their role. And so as far as those that are really dealing with the individuals who are emergency sheltered and unsheltered in that area.
Thanks, Cindy.
And we have no questions holding from the phone at all.
Do we have any questions online?
At this time, we don't have any more.
I'm sorry, we did have one queue up on the phone. Ann Goodwin, go ahead.
This is also for Cindy, and it connects with the answer that she just gave about, she was talking about the medical work group and getting the discharge planning done. That is something that I'm with the Continuum of Care in Alexandria, Virginia, and I'm also the SOAR lead and I'm the COC lead. So this has been a real struggle for us to try to pull together a group of people who have the authority to write the statements that they will do this, this, or this in order to help us make sure that people have housing when they come out of these institutions. So who was on that medical work group? How did you pull that together? Is it the same one that went to the SOAR things? Hello?
Hi, Cindy. Do you want to field that question about discharge planning and which administrator may have been on that work group?
Can you hear me?
Yes. Yes.
Okay, good. I'm sorry about that. The medical work group, that was referencing the source that I worked with within the SOAR. The planning group that it existed before the SOAR medical work group. And it still had to do with the 1115 waiver. It had to do with, I also have someone with the EMS on my continuing care board of directors, and there had been a couple of instances in communities surrounding Tarrant County of bad media around a unfortunate discharge of homeless individuals, and they got a lot of bad public relations from that. And we have our committee said, you know what, we can't ever let that happen, and so we just said it must happen. And that was really the motivation. That the embarrassing incident didn't happen in our community, but they've seen it in others and said, you know what, let's work it out. The other thing that we did is, we went to them and said, let us come teach you about homeless services. And so we started about every quarter being at the different groups and RNs and the psychiatric ward, nursing staff, and different staff within these hospitals, and said, let us come like a speaker's for, let us come and teach you about what's going on and educating them. And then that just helped draw them in and said, let us provide some education for you. Let's talk about when you make appointments for someone at this time of day, you realize that the bus system and this, that they won't eat if you make an appointment for this person, and just making them very sensitive of homelessness and the issue and their relationship, and that was just a way of saying, if they don't come to you, you just go to them and build a bridge and a friendship and say, how else can we help you? And that helps. And then they learned, one thing that we did was very creative. It just happened the end of January. Within my continued care, we do this group exercise once a year called Amazing Race, where teams of caseworkers from all the different agencies, we take off a half a day, and we do a competition, and we give them these crazy scenarios of homelessness or whatever, and they have to go all over the city and accomplish different things, kind of like the show Amazing Race. And the team builds, and then they come back and we debrief, and somebody invariably can't find the right bus. Somebody presents with different circumstances, and, we hand out crutches and wheelchairs, and they have to figure out how to get in the bus and take all their clothes. And it's fun, and it's not to make fun, but it's an education, especially for new case managers. The hospitals saw the media in that and said, we need to do that for us. And so it took a lot of planning, and they did that. This is private hospital, the public hospital. I think it was a group of 24 people. They went out, were handed scenarios of what it would be like in bus passes and say, you have to go to the doctor and you've got to go to shelter. And that was their exercise. And it was so eye-opening. Half of them never made it because they couldn't figure out the bus system. The other half would present with like an oxygen tank or whatever, and then realize they can't get in an emergency shelter with that. Or other, they had a companion animal and different things. And then suddenly these nurses and these discharge hospital caseworkers realized what they were discharging people into. And so that is going to be, so that's kind of how, that's the next level now. That just happened a couple of weeks ago. And so now they get it now. And we have the homeless helpline, the Coordinated Assessment Homeless Helpline.
Yes,
it's not just about homeless individuals. It's also for anyone in the community who encounters a homeless and just doesn't know what to do next. And so that's how we support the discharge planning.
I see. Thank you very much.
Thank you, Cindy, for that response with so many creative ideas. I'm sure everyone's busy writing those down with their pens. Cindy, I just have a question for you about the homeless helpline. Could that be utilized by discharge social workers and staff at hospitals to utilize, to call?
Oh, yeah, absolutely. It's on a little thing, and it's posted. And it's right now staffing. We tried to staff it like 80 hours a week, but there just wasn't enough calls to do that. So we've got a good core 50 hours a week. I mean, we call it a helpline, not a hotline, because a hotline denotes, 24/7. And if it's an emergency, you probably should do 911 or 211. So absolutely, that was part of our education distribution, was that absolutely that is open to caseworkers. Probably a third of the calls that come into our coordinated assessment phone line are caseworkers trying to figure out a problem, or hospitals, jail, police officers, firemen coming in and they're just not quite sure what to do. So it's a real service to the community.
Great. Thank you.
Pam, we have one more question that came in.
Okay. Great.
So the question is, we're still trying to come up with proper screening tools to make sure no one is falling in between the cracks, and obviously we want to be fair to everyone. So is the VI SPDAT the best tool to use?
Okay. I'm going to see if Will would like to field the question about the VI SPDAT, because he did talk about it, said it was great but not perfect. So do you want to just expand on that a little bit?
Yeah, thanks. So I'm definitely not going to say it's the best tool out there, partly because I'm not sure I have a good handle on the whole, universe of tools that could be used. I know it was better than what we were using. We initially used the vulnerability index, which is rooted in some research that says that it's a valid tool that prioritizes people who are at risk of dying. But it was the vulnerability index was really limited to our folks thought that it was a good tool for people who had known health conditions, medical conditions, and they wanted something a little broader. And so the VI SPDAT, we thought locally was an improvement. We're still trying to figure out if it's really reliable. Like it's supposed to help put people or recommend housing interventions, like either really intensive permanent supportive housing or rapid rehousing, or if you don't score as high, just kind of general affordable housing. So it puts people in those three categories, and we're not sure yet if it's making good recommendations. We do think it gives us a lot more information on the front end to help us prioritize. And but there's some tools, other tools out there that are on the NAEH website, and so we're in the middle of trying to figure that out. So if there are folks on the line or that have other tools that they think work well, I would love to hear about them.
Great, and I know your VISTA folks did put together some resources, and I do believe there are some tools within some of those resources. I know there's a toolkit and some other state examples. So please look through that and reach out to Will should you have any more questions about that. But it does look like we are out of time, so if we were unable to get to your question, please send that through the SOAR, through our SOAR website, SOAR email. We will field those questions, get them out to Cindy, Chris, and Will, and try to get those answered for you. So please feel free to send those questions on to us, too. So, again, I just want to thank the presenters, to all of you for participating. We do appreciate it. We know you are dealing with your point-in-time count. You are just so busy right now, so we do appreciate it. And to the folks on the line, please complete the brief online evaluation. It really helps us put together some webinars that meet your needs. And again, from our website or contact the SOAR TA Center at area code 518-439-7415 or our website soar@prainc.com. So again, thank you very much, and we look forward to seeing you on our next webinar next month. Thank you so much.
Thank you. That concludes today's conference. You may disconnect at this time. Thank you.